and also all the speakers and participants for today, the scientific Jaigas. As you know, we are in this is the fourth days that we have started since 2 weeks ago. Yes, sorry, since we start 1 week ago. Okay, for this morning, we have a plenary lecture for with the title of The Future of Endoscopy Training, the Role of Mastery Learning in Endoscopy. As you know that at present, most endoscopy training during fellowship is based on the what we call that the apprenticeship method, when the trainees learn directly through patient cases in the endoscopy unit. I think in this method, trainees need to perform high volume of cases and undergo a long training period to achieve the competency. I think this is really problems now in the pandemic era. Professor Roy will share the informations about what we call that in the future of our training. Hope so in this method that we can learn faster than before. Okay, now the time is yours, Professor Roy, please.
Good morning, Prof. Ari. Good morning, everyone. Can you hear me well?
Yes, Prof.
Okay.
Please continue.
Thank you so much for allowing me to discuss this very important topic. And thank you for your kind introduction of the importance of this topic in developing training in Indonesia. This slide came from many years ago, but it is still accurate before COVID. So before COVID, I think we probably trained about 40 trainees per year throughout the many different centers in Indonesia. And with COVID, both the volume and the quantity of the trainees also perhaps have gone down. And that's a problem because when we look at our need, so this is the number of person per gastroenterologist in the different countries. So in the United States, you can see there is one gastroenterologist for 15,000 population. In the Netherlands, is 1 in 55,000. But in Indonesia, we still have somewhere 1 in 300,000. So we are behind by about maybe about 20. We need about 20 times as many gastroenterologists if we want it as at the maximum level. But suppose we say we want to get more, like maybe 10 times more, so about a half of what we need. So that means that we need to create somewhere about 6,000 gastroenterologists very, very quickly because the economic growth of Indonesia is quite fast and there is a rapid development of the middle class, and they will in the future require a lot more of the subspecialty care. At the same time, we have an explosion of knowledge in endoscopy. So if you see There are so many new technology, new subspecialty in endoscopy, including the bariatric endoscopy now, and the many other very invasive EUS ERCP technique. And all of these things come with also work limit for the fellows, and also with the explosion of the literature. So it's very hard to keep up with the knowledge to practice all aspects of endoscopy. So this is the question, how do we train more? But we don't want to just train more, we want to train quality endoscopists. And it's a challenge because the issue that we have is really our methodology to train has not been updated for 100 years, maybe. It hasn't been really updated for a long time. So this is the first uh, description of the see one, do one, teach one in 1904. So it's Professor Halstead in surgery showing to all of his fellows surrounding him. And he would say, look at this, you see one, then you can do the next one, and then you can teach the next trainee. Uh, and surgeons for a long time have been doing that. And endoscopy started somewhere in the 1940s at the University of Chicago by Schindler. And it was really a branch of surgery. So we then just follow whatever the surgeon say the best method to train. And in 1985, there was a new technique in surgery, laparoscopy, laparoscopic cholecystectomy. And many surgeons says, well, okay, we'll do, we see one, then we can do one, and then we can teach one. And they were suddenly got into a lot of trouble because they had many bile duct injuries. Patients were not doing well when they were using the see one, do one, and teach one. And they say, wow, this is something that's very different. We now know that our training method doesn't work. So we now know that there are many limitations to this methodology because there's a lot of variation in the competency. It is very inefficient. With the era of COVID, this becomes super inefficient because then it takes so long to perform a procedure. With the COVID, it takes even longer, and the trainee is there and makes it even extremely difficult. And the other problem is that we cannot suddenly train many people when we have this apprentice-based pedagogy. And more now people ask about the ethical question. Is it ethical that a trainee that has never done endoscopy perform the first endoscopy on a patient? Why couldn't the trainee learn using a model first before they come and do on a patient? So there are a lot of issues with the old pedagogy. So the surgeons are quite clever. They actually have adapted what the ACGME wanted. They say, okay, you say we wanted to, you wanted us to be competent based. We will create the curriculum. They put their curriculum in the cloud. They make it interactive. They make it case based. They make it self-learning. And they also the surgeons are very very used to using simulators. So they use simulators to learn, and they also are tested before they can get their board certification using simulators. And what do we do in gastroenterology? Well, we just say, well, we now have a competency base, but we actually don't change that much. So in the gastroenterology training in the US, actually, the method of training have not changed that much. We just add more years. So if you want to learn more ERCP, you add one more year. You want to learn EUS, you add one more year. You want to learn bariatric, you add one more year. And before you know it, it takes so long to learn anything. And still, the result is very variable. And there is no accreditation to say that you are competent. So this morning, I wanted to share with you the concepts of mastery learning. And hopefully by the next GGES next year, we will have some courses hands-on that's based on mastery learning. So what is mastery learning? Well, this is the traditional approach. The traditional approach is that we grade the students, the trainees, on a curve. And we say anybody who is not in the lowest 5%, they pass. So anybody can pass as long as they are not in the lowest 5%. And the problem here is that maybe what the patient needs is not in the lowest 5%. The patient may need somewhere in the high levels to be able to get their bleeding stopped, to be able to get their stone removed using endoscopy. So suppose we say they only if they are in the top 80%, then they are actually can deliver good quality endoscopy care. And that means that we need to move everyone to be above a certain limit. And that's why it is called the mastery learning, which is to say that you can finish only if you pass a certain high level achievement. So the question that you will ask is that how do we do something like this? How do we move from something like this to become something like this? And this has been studied and it's actually been used. It's been used by many other subspecialties. For example, when we take ACLS, Advanced Life Support, that is a mastery learning based training because they want to pass a certain level that's very high so that when somebody needs a CPR and needs an ACLS, you actually can deliver it. So mastery learning is competency based, meaning that you can finish only when you're competent. And the key part is that the trainees learn deliberately, and it's a deliberate practice. And I will discuss with you what that means. This word means a lot. It doesn't mean that you just practice as you think you are practicing, but you practice like the tennis champions, the music champions, and things like that. And the trainees are required to pass a certain level that the trainers determine. As I mentioned, it is used everywhere else, perhaps except in GI. And the effect is superior. And more importantly, is that the variation is very small. So this is the concept. The concept is that after they do self-preparation, they do their training with deliberate practice. And we'll go into detail what the deliberate practice means. And then they also get a very specialized feedback so that they can learn fast. And then they are assessed continuously. And if they are not yet passing, then they keep going, training until they pass. So there is a certain level that they must pass let's say they must pass at 80%, then they keep just practicing until they pass. The essence here is that time is given to the trainee so that they can practice as they need to pass, rather than we say, okay, uh, you are going to learn upper endoscopy in the first 3 weeks or first month, and whether you pass or not, we are going to teach you colonoscopy. Well, that becomes a problem because then they are not able to do certain maneuvers, and then they have to do something more difficult, and that is just doesn't work. But if we say, okay, we have a model, you can learn until you are passed on the model, and then you can do it on a patient. You can go back to the model to practice more, and then to the patient. And then when you can do upper endoscopy well, then you can do colonoscopy. Then you can see that the results can be much better. So what about deliberate practice? So deliberate practice is a different type of practice than what we now know. The practice that we now know is that, okay, there is a patient coming in room 2, and please perform the upper endoscopy. There is really no specific steps that you are saying you must be able to do these steps. It is very unspecific. You expect the trainee to perform from the beginning to the end, but they may not have all of the parts, and they cannot practice the specific parts whereby they have difficulty. Uh, and the practice must be focused. So if you say, well, you cannot do these steps, retrofraction, then we will make you practice that part again. It has to be challenging, meaning every day it becomes more harder, more complex, and then they get to the point of being able to do it very well. There must be a good feedback, and need to have a coach that gives them the feedback. It doesn't have to be all the time, but the feedback has to be very, very direct, specific, and it really helps them. So this is a different type of practice than what we know. And whenever mastery learning is compared to the traditional apprentice-based learning, is always better than the apprentice-based learning. And the effect is very, very significant. It's about 2 times in the distance of how well this technique is. So that's mastery learning. So how do we put it into endoscopy? We have tried it many different ways. This part is usually missing in the training, which is the endoscopic tip deflection. We teach them first how to handle the endoscope. We teach them the knowledge at the same time, and then they practice on the model. They practice on the model until they are competent before they go to do therapy and before they do on a patient. So all of the steps are very standardized, is structured, standardized. They can repeat it. They can repeat a specific part of it whereby they are not comfortable, they cannot do it yet, and they repeat until they can do it. They learn the therapy after they learn the basic part. And they also learn the knowledge. And then at the end, we have an independent assessor to make sure that they have reached the mastery level when they do this specific task. So this is, for example, the trainee in the beginning, they don't know how to hold the endoscope. They don't know how to manipulate the endoscope, and they must do it until they are at the level of the expert. They hold it like this, the certain way. They hold it right, and all of their fingers are working. And only after they can hold the endoscope well, then they perform a standardized upper endoscopy. And here we show that they can become competent within training of about 2 or 3 full days of learning upper endoscopy on the model. And they can learn the different therapies as well. And when we follow them with time, they also show that they are able to practice it in their clinical settings. This is just some pictures of showing that the mastery learning also work for practicing endoscopists to learn how to use the over-the-scope clip for bleeding. And this part I would also like to share with you because I think this is very important, whereby we show that we can use the Zoom technology combined with the simulation and mastery learning to train trainees from parts of the Southeast Asia and United States. And I'm going to share with you what we saw. So we had a 1-week course. They learned the handling. They learned the structured upper examination. They learned how to do biopsy and clipping. And we had 21 trainees with 7 trainers. And you can see that they barely were doing endoscopy. They didn't do that many colonoscopy. And then we train them all of these parts: tip deflection, structured upper, electrocautery, clipping, and so on. We use the Zoom to reach to them. They also have their local trainers to help them when they don't know how to hold the endoscope, for example. We show it and then we make sure that they get the right feedback so that they can reach their competence. So again, everyone reach competence with the same speed as if we just do direct training. And when we measured their capability to perform an upper endoscopy, so this is a very structured exam to make sure that they examine all parts of the stomach, esophagus, and duodenum very carefully. We show that they are reaching the mastery level. The part I wanted to show you is we don't have as many fellows, but here we have 9 fellows that had direct training. So the trainers were with them. And then we have 12 fellows that had the virtual coaching only. And you can see that their scores were very, very similar. So this tells you that maybe one day we have the trainers be at RSJM, and then the trainees could be in any parts of the country in Indonesia. And as long as both the trainers and the trainees have the same simulators and they're connected, then everyone can learn. So there is this very potential to make training much more efficient and effective. Do they like it when they have the virtual coaching and learn on their own? As far as we can tell, they are very happy to have the virtual coaching. Of course, many people will say, oh, sure, it would be better if we have the trainers right next to us. But I think we are looking at the era of post-COVID, whereby it would be quite a number of years before we can restore the same type of training as what we used to be. So I'm encouraged, for example, that now vaccinations are available. But as you can see that it will take a long time before all parts of the world will be vaccinated. And we still have challenges. There'll be a mutant virus. There are just so many unknowns there that we need to also develop technologies whereby we can deliver training to be continuous to all parts of the world that will need more of the subspecialists. What do we see from the combining mastery learning, simulator, and virtual coaching? We see that they all actually work synergistically because suddenly we can train a lot more people by combining these three parts. With that, I want to conclude and give some time to perhaps get a few questions. And I just want to say that so far what we've seen is that it's very useful. It is expected to be useful because it's been used in many other subspecialties. With the virtual coaching, it becomes even more useful. And our plan is that in a couple of months, we'll have some trainers from RSJM to learn how to make curriculum of mastery learning. And then we will start to bring it to our members in Indonesia as well. Thank you so much.
Good, thank you, Professor Roy. I think, yes, you have shared the information to us that we need to change from traditional training method to mastery training method. And thank you for your proposal. And also, I think this is our future for the training center. And thank you. You also included us, Jakarta, and also some other place in abroad. So yeah, I agree that I think we can start to do that in the middle of 2020. Because of this is from this session, because it's plenary lecture, so there is no question. But I think Professor Rai will answer your question by email. I mean, maybe if any participant want to know more about the topics that Professor Roy mentioned this morning, I think Professor Roy will be happy to answer your question by email. Okay, Prof. Roy?
Thank you so much, Prof.
Yes, thank you, and also for all participants, thank you very much for who joining this session this morning. And I move to Dr. Saskia to continue the session. Thank you very much. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Prof. Ari and Prof. Roy. But first, we gotta take a picture, Prof. So you may please look at the camera. I will count in 1, 2, 3. Okay, once more. 1, 2, 3. Okay, thank you very much to professors for your very, very insightful lectures. So ladies and gentlemen, right now we are going to see one of our video from the gastroenterology. So please take a look.
Endoskopi ultrasonografi atau EUS adalah tindakan minimal invasif dengan menggunakan alat endoskopi yang dikombinasikan dengan pemeriksaan ultrasonografi. Dengan tindakan ini, kita bisa melihat lebih detail mengenai organ-organ di sekitar abdomen, di sekitar perut seperti hati, pankreas, ginjal getah bening, dan dinding saluran cerna lebih detail. Tindakan ini juga bisa dilakukan dengan menggunakan biopsi jarum halus sehingga dokter bisa mendapatkan sampel cairan atau sampel biopsi atau mengeluarkan cairan dari dinding perut secara minimal invasif. Tindakan ini merupakan salah satu alternatif yang non-invasif dibandingkan tindakan pembedahan secara langsung. Endoskopi ultrasonografi diindikasikan pada kelainan-kelainan di saluran cerna, seperti misalnya kista di pankreas, atau cairan di pankreas, atau tumor di pankreas, atau kelainan di saluran empedu. Misalnya ada kecurigaan ke arah tumor saluran empedu atau batu saluran empedu yang masih meragukan, maka bisa dilakukan tindakan ini. Indikasi lainnya adalah tumor-tumor di saluran cerna yang membutuhkan pemeriksaan lebih detail keterlibatan lapisan-lapisan saluran cerna. Juga bisa dilakukan tindakan ini.
Selama prosedur, perangkat ultrasound kecil terhubung dengan endoskopi. Endoskopi adalah tabung kecil bercahaya fleksibel dengan kamera terpasang. Dengan memasukkan endoskopi dan kamera ke saluran pencernaan bagian atas atau bawah, dokter dapat memperoleh gambar ultrasonografi organ yang berkualitas tinggi. Karena EUS dapat mendekati organ yang diperiksa, gambar yang diperoleh dengan EUS seringkali lebih akurat dan detail daripada gambar yang diberikan oleh USG tradisional yang harus dilakukan dari luar tubuh. Kapan EUS dilakukan? Pertama, untuk evaluasi stadium kanker. Lalu, untuk evaluasi pankreatitis kronis atau gangguan pankreas lainnya. Kemudian, untuk mempelajari kelainan atau tumor pada organ, termasuk kantong empedu dan hati. Kemudian, untuk mempelajari otot-otot rektum bawah dan saluran anus untuk menentukan alasan terjadinya kebocoran usus yang tidak disengaja atau inkontinensia. Dan yang terakhir, untuk mempelajari nodul atau benjolan di dinding usus.
Endoskopi ultrasonografi sudah dapat dilakukan di Pusat Endoskopi Saluran Cerna Rumah Sakit Pusat Cipto Mangunkusumo. Alat ini memang masih jarang didapatkan, memang hanya pada center-center besar seperti di RSCM.
Okay, ladies and gentlemen, the second agenda is Symposium 6 with the topic Diagnostic and Management of Constipation, sponsored by Meiji. For this symposium, it will be moderated by Dr. Rabinu Rangga Pribadi from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia. Without further ado, I would like to invite Dr. Rabinu Rangga to please lead this session. Thank you.
Okay, thank you very much, Dr. Saskia, for a kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all the speakers, Professor Dadang, Professor Murdani, and Dr. Fauzi, and of course to all participants. It's me, Dr. Rabinu, and I will be the moderator of this session. Let us proceed to the Symposium 6 with the title Diagnosis and the Management of Constipations, which is also supported by Meiji. As we all know that constipation sounds like a simple problem, yet it is a very debilitating condition for the patients and frequently frustrating for us, the clinicians, to manage it. Luckily, a national consensus had been launched by the Indonesian Society of Gastroenterology and is developed with the specific conditions in Indonesia. And I have to say that the armamentarium for the medication of the constipation has been added recently with the addition of polyethylene glycol or PEG. We are already familiar with PEG for colonoscopy preparation, but is it still efficacious for the bowel preparation? And is it recommended for a chronic constipation? And we will find out the answer in this symposium with three outstanding speakers. The first speaker will be Professor Dadang Makmun, MD PhD, with the title The Update and the Management of Chronic Constipation, the Indonesian Perspective. Professor Dadang is the head of Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. He is also the president of the Indonesian Society of Gastroenterology. Professor Dadang, the time and the stage is yours.
Yes, thank Thank you, Dr. Abinu. Share screen. Yeah. Thank you, Dr. Rabinu, Mr. Chairman, and all our colleagues from all around the country. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
This morning, my assignment is to deliver a talk about the update in the management of chronic constipation, the Indonesian perspective.
Slide-nya belum full screen, Prof.
Yes, this is the outlines of my talk. And next slide. Next slide, please. Yeah. As we have already known that constipation recently is a common GI disorder in our clinical practice, a significant healthcare problem in the community, and most of chronic constipation patients are aggravating. And even though not life-threatening or debilitating. Sorry. I'm sorry, this is a technical problem. Gimana? And in such situation, constipation could become a chronic disorder, which finally can interfere the daily activities and of course will impair their quality of life. And nowadays, due to the advances of on the medical technology, the availability of medical centers, and the increased awareness on health, more patients are seeking for a cure of the constipation. And this is the epidemiology data about chronic constipation worldwide. And if you look at this data, Indonesia with the yellow part, it means that the prevalence of chronic constipation between 10 to 15%. Even though we have no population data about chronic constipation in Indonesia, and mostly the data come from the hospital or hospital-based data, and from our hospital in Jakarta, in RSCM, among more than 1,200 colonoscopy, we find that about 6.5% colonoscopy was underwent due to chronic constipation. What is the risk factor and pathophysiology of chronic constipation? Experts believe that female more common than male, and then patient with lack of physical activity, inadequate water and fiber intake, and maybe with the use of chronic medication with polypharmacy especially, and especially of course patient with the misuse of laxative and some other comorbidities who are the risk factor for chronic constipation. And if you look at the history of reverse chronic constipation, idiopathic slow transit constipation, psychological factors like patient with depression, patient with anxiety, and insomnia more prevalent to have chronic constipation. But just a little bit questionable that among persons with low income and low education seem to have more prevalence with chronic constipation. How about the body mass index? Mostly persons with body mass index more than 26 maybe have the more prevalent with chronic constipation. This is the proposed pathophysiology of chronic constipation. We know that constipation is divided into two parts, including primary or functional constipation and secondary. The term of secondary constipation refers to the constipated patient with intra or extra intestinal disorder, patient with metabolic disorder, myopathy, neuropathy, and maybe due to some effect of the drugs. But the patient with primary constipation, we can divide into four groups, including normal transit constipation, slow transit constipation, rectal evacuation disorder, and combination of slow transit and rectal evacuation disorder. Right. And we have to note that the diagnosis of primary constipation is established only after all possible etiology of the secondary constipation have been excluded. Like this. This is some disease or condition that can lead to chronic constipation. The first is intra or extra intestinal disorders such as thrombus, hemorrhoid, endometriosis, patient with anal fissure, megacolon, rectocal, and of course some patient with colorectal cancer. And the second, patient with metabolic disorder, diabetes mellitus, more specific diabetes mellitus shown to have more prevalent of chronic constipation. And again, hypothyroidism, patient with hypokalemia, hypomagnesemia, and among patients with uremia. And finally, patient with myopathy and neuropathy. Slide. Other conditions that can lead constipation including depression, degenerative articular diseases, autonomic neuropathy, patient with cognitive impairment, and among patients with sedentary or immobilization. Slide. This is some medication that can contribute to chronic constipation. So we have to know, we have to be aware. If we prescribe some medication, especially with polypharmacy to the patient, be aware about the use of opiate, anticholinergic, patient medication for Parkinson disease, symptomatic, antipsychotic, and diuretic. And again, maybe we all every day in our practice prescribe the patient with antacid, especially aluminum containing antacid. So these can contribute to constipation. Slide. And we have to be aware if there is some alarm sign, patient presenting some alarm sign requiring prompt further evaluation, including patient with rectal bleeding, unexplained weight loss, patient with persistent nausea or vomiting, patient with iron deficiency anemia, patient with prolonged fever, or patient with abdominal mass. But according to the age, all patients with chronic constipation in the age above 50 years old require further evaluation, including endoscopy. Slide. And what are the four investigations required for patients with chronic constipation? The first is rectal balloon expulsion test, or RBET. This is a very simple test. So we can make this test. We can perform this test in our hospital, in our clinic. This test can evaluate patients' ability to evacuate water-filled balloon that is inserted into the rectum, and normally within 1 to 5 minutes, normal individual can evacuate this water-filled balloon. And the second is anal manometry. Manometry, I think, right now, especially in Indonesia, only limited in the sophisticated center. Yeah, but this manometry, this anal manometry can evaluate pressure in anorectal area, can evaluate rectal sensation, anorectal reflexes, and anal sphincter function, and can detect this synergia defecation or patient with Hirschsprung disease. But again, this modality should be done only among patients who are unresponsive to such laxative. The third is endoscopy. This is advised for all patients with constipation with age above 50 years old, at least for the colorectal cancer screening. Colonic transit test is not too difficult to be carried out. We can use capsule containing radio-opaque markers and 24 capsules swallowed in the first day. Then we evaluate until 5 days later. The result of abnormal transit time is considered if more than 20% of markers are still inside the colon until 5 days since the first day of the test. And the last is the phagography. I think is very, very limited. And we in our hospital are going to provide this kind of tests. And of course, the significance of this test very beneficial to evaluate patient with chronic constipation. Slide, please. The problem is arise when all patients with chronic constipation try to treat by themselves to find some medication not only available over the counter, but also maybe some herbal medicine that can easily assess it by the patient. Sorry, again. For example, we can easily find such as teh daun jati Cina, again, laxing, and again, and many more, merit. But if we try to evaluate the content of this kind of quote-unquote medication, we have to be aware of the content of this, because some of this modality containing anthraquinone, that if you use anthraquinone in the long term can lead to what we call as melanosis coli. Melanosis coli is the deposition of melanin in the mucosa of the colon. Even though this situation is reversible, but again, we have to be aware about the long-term effect of this kind of complication. Slide. Again. So this is the algorithm of the management of chronic constipation. So if can you okay. Among patients with chronic constipation, the first step to be taken is history talking completely, and of course physical examination, and then maybe the basic laboratory studies should be carried out. And please consider the test for metabolic disorder such as diabetes mellitus, hypothyroidism, and of course colonoscopy. After that, we can try to give the patient empirical therapy using fiber and laxative. And if the response is inadequate, so we can proceed to anorectal manometry or rectal balloon expulsion test. If the result is normal, we can proceed to colonic transit test, and there will be normal colonic transit or slow colonic transit constipation. But if the result is inconclusive, we can proceed to the barium study and the phagography. And if anorectal manometry or rectal balloon expulsion test is abnormal, better we have to refer it to the center who provide the phagography test to find the phagography disorder. Slide. And then this is the algorithm of the management of slow transit constipation and normal transit constipation. Laxative could be initiated promptly. We can use stimulant or secretory laxative. That if there is improvement, we can continue the therapy regimen. But if there is no improvement, we can repeat colonic transit test during medication. I think this is similar to the previous algorithm. If the result of colonic transit is slow colonic transit, consider gastric emptying if necessary. And if the gastric emptying is slow, consider to follow-up test for the upper GI motor disorder or esophagogastroduodenoscopy. But if the result is normal, so finally we can consider colon manometry test or barostat. And if the result is still normal, maybe finally we have to consider temporary loop ileostomy. And in such patient, if the result of is abnormal, finally we can consider for surgical intervention such as subtotal colectomy or ileorectal anastomosis. Slide. And I think it's very important, the algorithm of the management of chronic constipation in primary healthcare services. Among patients with constipation, we have to be aware about the alarm sign. Alarm sign, including as at the onset more than 40 years old, the possibility of secondary constipation, and the abnormalities on digital rectal examination or DRE. And if there is no alarm sign, there is no possibility of secondary constipation, and the digital rectal examination is normal, we have to initiate empirical therapy, including lifestyle modification, use of laxative for 2 to 4 weeks. And if the response is good, we can continue the medication. And if there is no response, further investigation required. And we we have to refer to the high level healthcare services. Slide. What are the treatment options of chronic constipation? Again, we have to initiate lifestyle modification first, then maybe concomitant with pharmacologic and non-pharmacologic treatment, and maybe in very, very limited fashion, we required surgical intervention. Education is very important. We have to explain the patient regarding to what is the constipation. We have to educate the patient about the diet and lifestyle modification that can lead to the improvement of the symptom. And we have to encourage the patient to reduce the use of laxative. It means to avoid habituation or tolerance among the long-term laxative user. And the second is diet and lifestyle. Experts believe that higher fiber containing foods is beneficial. Patient should be educated to take adequate water, minimum 30 to 50 milliliters per kilogram of body weight, and then to increase physical activity and to train bile habit, including avoid straining. Try to defecate after breakfast, because this maneuver can lead to the what we call as postprandial bowel movement reflex. And the last, intervention. The first, of course, fiber and bulk forming agent, such laxatives such as osmotic laxative, stimulant laxative, secretory stimulant such as lubiprostone, prucalopride are not available in Indonesia right now, and then such suppository, probiotic, biotic therapy, and PEG. PEG is polyethylene glycol. Slide, please. This slide shows us the effect of lifestyle modification on the severity of constipation and the quality of life of elderly in nursing home in Egypt. This study conducted by Habatallah Nur Eldin et al., and they concluded that education on lifestyle modification leads to an improvement in the severity of symptoms of constipation and the quality of life of the elderly in nursing homes. Slide, please. And again, what are the role of dietary fiber in GI condition, especially constipation? Experts believe that a high fiber diet may be protective against and therapeutic useful in the treatment of constipation. A gradual increase in fiber intake through the diet and or supplementation to at least 20 to 30 grams a day with adequate fluid is recommended. Additionally, such as psyllium supplementation may be appropriate in the management of chronic constipation. Slide, please. The effect of dietary fiber on constipation. This is the meta study conducted by Jing Yang et al. They concluded that dietary fiber intake can obviously increase the stool frequency among patients with chronic constipation. Slide, please. And the next, still about the exercise therapy among patients with constipation. Systematic review analysis conducted by Gao et al. They concluded that exercise may be a feasible and effective treatment option among patients with chronic constipation. Slide, please. And the last is the use of drugs. Drugs that could be used in the management of chronic constipation and nowadays are widely available in Indonesia. The first and the very simple one is bulk laxative agents such as psyllium, plantago ovata, or methylcellulose. And the second is the group of osmotic laxative, including saline laxative, magnesium hydroxide, or milk of magnesia, non-absorbable disaccharides such as lactulose, and sugar alcohol such as sorbitol and mannitol, and then polyethylene glycol or PEG, who recently widely available in all around the country. And the third is stimulant laxative. I think this is the eldest one, including bisacodyl, senna fiber, castor oil, or sodium picosulfate, and deoctyl sodium sulfosuccinate. And number 4 is secretic stimulant, lubiprostone, and right now already available in Indonesia also. And some rectal enema or rectal suppository containing phosphate or bisacodyl enema. Experts believe that probiotic take an important role also in the management of chronic constipation, and in a very sophisticated center, we can provide biofeedback treatment for patients with chronic constipation. Right. We have to be aware about the management in special population. The first is among elderly. Why elderly is very important to be aware with long-standing constipation. A population-based study report that the cumulative incidence of chronic constipation is very high in the elderly, among 20% compared to a younger population. And then the second, severe constipation is more common in the elderly women, with the rates of constipation 2 or 3 times higher than that in their male counterparts. So it means women more prevalent than male. And such epidemiology studies demonstrate a higher prevalence of laxative use in the elderly, and elderly patients residing in nursing home have a greater prevalence of constipation, maybe up to 50%, with up to 74% of them using daily laxative. And we have to know that the two major etiologies of constipation among elderly, including pelvic fluid disorders and slow colonic transit. This is such proposed psychological colonic changes in the elderly, including decrease of propulsion, slow colon transit, weak sphincter, decrease the sensor motor function, impaired reservoir function, and again can lead to constipation, fecal incontinence, fecal urgency, fecal seepage, and finally patient require the use of chronic laxative. The etiology of constipation among the elderly, including impaired of function, the propulsion, and the slow chronic transit. And the principle of treatment are similar to the younger patient, but we have to give more attention for fecal infection. More patients with chronic constipation in the elderly might need manual disinfection or manual fecal evacuation, and sometimes they require enema or suppository. Stimulant laxative in the elderly should be used with caution. Slide, please. What are the laxative that could be used among patients with chronic constipation in the elderly. The first is the selection of treatment should be depend on the underlying physiologic cause. In the elderly population, it is important to consider other factors that impact constipation. The second, commonly, fiber supplementation is a reasonable initial therapeutic approach. But however, patients that do not respond to fiber supplementation can be advanced to osmotic laxative use. The latter should be titrated to clinical response, and again, stimulant laxative and prokinetic agent should be reserved for patients who are refractory to fiber supplementation or osmotic laxative. In a very, very small patient, surgical intervention finally indicated for chronic constipation. Exclusion of pelvic floor disorder is essential, and surgical outcome in the elderly are uncertain. If you look at this table, some laxative agent could be used among patients with the chronic constipation in the elderly, including bulk and Senna, PEG, polyethylene glycol, and the lubiprostone, prucalopride, and electrolyte, who are until unavailable in Indonesia. Slide. Traditionally, the first line of pharmacoagent should be lactulose, sorbitol, and Senna. But, however, in studies that involve geriatric population, Senna conditions have shown greater efficacy and more favorable side effect profile. Sorbitol had roughly the same efficacy as lactulose, but had a better side effect and cost profile, an alternative to using lactulose. And again, polyethylene glycol or PEG, I think now they are a product of PEG. The name is Dilax. Is another osmotic laxative. Was shown to be effective in geriatric population in comparison to general adult population. But interestingly, geriatric patients did not have more side effects than the general adult participant. Slide, please. This is the algorithm of the management of chronic constipation among the elderly. We have to be aware, because it could be because of colonic transit, slow colonic transit time, because of the abnormality of the anorectal, and such tests may be required, including colonic transit tests, anorectal manometry, balloon expulsion test, and defecation test. Combination of medication, including bulking agent or cosmetic laxative such as polyethylene glycol with prokinetic agent, or combination as mentioned before or after enema or short-term stimulant laxative. But we have to be aware if there is the possibility of pelvic floor function disorder. Maybe bowel training is required, such as biofeedback. Multidisciplinary team should reassess the comprehensive and adjust the treatment strategy. And in such limited patient, surgical intervention may be required for elderly with refractory severe constipation. Slide, please. And the last is the management of constipation in pregnant women. Of course, it is very prevalent, very common if women with the third trimester of pregnancy presenting of constipation, and the treatment of choice, including high fiber containing food. So the patient should increase the water intake, and of course, prenatal exercise. Laxative could be used if the symptom does not improve after initial treatment with high fiber containing food and water intake. Any medication are used for short period only, and bulking agents are considered more safe for the pregnant woman compared to the stimulant laxative, and bulking agent and lactulose are not absorbed in the intestinal tract, so bulking agent or lactulose is safe for pregnant and lactating women. Slide. And again, still in the management of constipation among pregnancy, a study in Shanghai showed that the prevalence of functional constipation among pregnant women almost 13% and higher than among the general population, which is only 6%. Pregnant women who were more than 35 years old with a pre-pregnancy body mass index more than 24, who were highly educated and employed in sedentary occupation, showed a higher prevalence of functional constipation. So this is very important. So after pregnancy, almost all women take less exercise, which is one of the most common cause of constipation among them. And in this study, multivariate regression analysis showed that moderate exercise was a protective factor for the prevention of functional constipation in the pregnancy. Some medication could be used among patients with with constipation in pregnant women, including psyllium, docosahexaene sodium, again polyethylene glycol, bisacodyl, sena, and then the most safe is lactulose. But again, the use of laxative should be given in the short term only. Slide. What are the complications of chronic constipation? The first and the most important is fecal infection or fecaloma. Heart fecaloma can lead to the pressure of intestinal wall and can lead to the vascular compression, will diminish capillary perfusion, and finally can cause intestinal ischemia, followed by inflammation and necrosis, stercorrhosis, colitis, and ulcer development or stercorrhosis ulcer, maybe finally could cause perforation. And the fecal infection with rectal distension can also lead to the urethral and bladder compression and finally can cause the urinary retention. And the prolonged contact of feces and intestinal wall with can lead to mucosal irritation and will increase the secretion, will prolong internal anal sphincter relaxation, and will decrease anal sphincter tone, especially in the elderly, with neuropathy, and fecal incontinence and paradoxical diarrhea or overflow. And the second complication is hemorrhoid. Hemorrhoid could be developed among patients with constipation, was found in 38 of 78 patients with constipation who underwent colonoscopy in our hospital in 2016 to 2017. And the last is anal fissure. Anal fissure, and then slide please, and rectal prolapse are also complication of chronic constipation. Slide please. Our college, let me conclude my talk. The first is constipation is a common GI disorder that could impair the patient quality of life. And of course, the evaluation of patient with constipation begins with history taking, careful physical examination, and further investigation that is tailored to each patient. And medical practitioners should be able to recognize and its alarm sign to ensure appropriate management for every constipation etiology. Slide. Advancement of the available diagnostic and treatment modalities allow us to diagnose and to treat patients with chronic constipation according to the available modalities. Right. Our society already established the revised national consensus in the management of chronic constipation in Indonesia. And I think this consensus will be delivered to all doctors in all around the country. Slide. So thank you very much for the attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Dadang, for the comprehensive explanation. Let us proceed now to the next speaker, Professor Murdani Abdullah, MD, PhD, with the title PEG 3350, New Modalities in the Management of Chronic Constipation. Professor Murdani is the head of Human Cancer Research Cluster, Faculty of Medicine, Universitas Indonesia, and he is also the lead investigator of PEG study for chronic constipation in Indonesia. Please, Professor Murdani, the stage is yours.
Thank you, Dr. Abi, for your kind introduction. Can you hear my voice?
It's clear, Prof.
Can you hear me?
Yeah, we can hear you.
Okay.
Please proceed.
Can you see my screen?
Yeah, your slide is clear. We can see it.
Okay, thank you. Well, first of all, I would like to thank Professor Marcelo Simadibrata, the chairman of this wonderful symposium, and Professor Dadang Makmun, the president of our Indonesian Society of Gastroenterology, and Professor Fahri Al-Sham as a president, and Dr. Kaka as a general secretary of Indonesian Society for Digestive Endoscopy. Well, colleague, it is really grateful for me to see you all in this online platform in this special occasion. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Well, my task today is to talk on PEG 3350, new modalities in the management of chronic constipation. I think previously Prof. Dadang Makmun has mentioned that PEG is the first line treatment of constipation, so it really makes my job easier. So I would like to start with the fact that chronic constipation is a very common gastrointestinal problem. Reported prevalence of constipation quite varies across the studies. It's ranging from 2 to 30%. Constipation may adversely impact patients' quality of life and high economic burden. What we mean with chronic constipation, I think as clinician, we used to deal with this problem in our daily practice. But what about the management? I think I agree with what Prof. Dadang has mentioned before, that the initial management are lifestyle modification and dietary fiber. Those are a wide variety of pharmacological agents, including bulking agents, laxative, osmotic and stimulant, stool softener, and prokinetic has been used to treat constipation after the initial management failed. Studies supported that osmotic laxatives such as lactulose and polyethylene glycol, PEG, are effective and safe for children, adults, and the elderly, also recommended as a first-line medication. Those are PEG. We recognize PEG as an odorless, tasteless, non-absorbable, non-metabolized agents, inert polymer in powder form, soluble in water, that is not fermented by bacterial flora. If you look at the form of PEG in the market, is available in PEG 30C50, PEG 4000, and in this case, PEG 30C50 is more hygroscopic, suggesting a higher potency on a per gram basis. Those are also PEG with electrolyte. The addition of electrolytes does not appear to provide any additional clinical benefit, but in opposite, it creates some adverse event. PEG we know that PEG forms hydrogen bonds with water molecules, and this bonding only binds with water that is orally ingested. That's why PEG usually to be swallowed with amount of water. And PEG prevent the reabsorption of water, water retention in the stool, and increase the osmotic pressure. This the mechanism of PEG to induce bowel movement. And stool softens and bowel movement occur more frequently after PEG ingestion. Um, well, those are plenty of study to show to compare the PEG versus placebo. I would like to mention some of them. And most of the study clearly showed that PEG group induce more bowel movement compared to placebo. So what about if the PEG plus electrolyte? It seems give us mostly the same result, that PEG and electrolyte have induced more bowel movement compared to the placebo group. Then there's also some study to compare PEG versus lactulose. Those are systematic review of randomized clinical trial comparing PEG and lactulose, and reported that PEG is better than lactulose in outcome of stool frequency per week, form of stool, relief of abdominal pain, and the need for additional product. Those are some study to compare PEG and lactulose by Attar, Mushnik, Kendi, Grimsey, Fakuil, and most studies showed that PEG mostly better than lactulose, but some are also showed non-inferiorities that the PEG to lactulose. Well, I think it is interesting to know there is quite a lot of study to show this result that PEG non-inferior or somehow better compared to lactulose to treat constipation. If you look at the adverse event, may I go back to previous slide? Sorry. Well, somebody can show me how to go back to my, well, this is the effect of PEG comparing to lactulose in terms of spontaneous bowel movement per week. It seems that the effect of PEG and lactulose will work at the first week and maximum at the second week, and become flat at the third and fourth week. What about the PECSIM? PECSIM is the symptoms of constipation, including straining or the bowel movement. It showed that the symptoms decrease from both groups. So I think PEG and lactulose are quite effective to induce bowel movement and to decrease the symptoms of constipation. Again, if we look at the some problem with defecation in constipation situation. Both group, PEG group and lactulose group showed a similar in straining sensation of incomplete evacuation or long duration of evacuation. This is a quality of life from both group, PEG and lactulose. Overall, it showed a similar impact on quality of life among constipated patient. Well, what about adverse event? Diarrhea seemed to be more frequent in PEG group, while nausea, abdominal pain, much less in PEG group. This is our study. This is a non-inferiority study to compare the efficacy and safety between PEG 3350 and lactulose for the treatment of chronic constipation. We have finished this study last couple months during the pandemic area. This study recruited almost 200 patients with chronic constipation and being randomized into two groups. First group to be administer PEG, and the next group with lactulose. We found 89 subjects include in the PEG group and 86 subjects belong to the lactulose group. And we performed study for 2 weeks, and we do ITT and protocol analysis. We found the characteristic of our subject mostly female, as Prof. Dadang has mentioned before. And you can see here that the age of the patient with constipation mostly productive age group, less than 40 and between 40 to 60 years old. Yeah, this is our primary result is the spontaneous bowel movement. We can see here clearly that both group, PEG group and lactulose group, has induced improvement in spontaneous bowel movement during the first week, and again the better improvement after 2 weeks, and both group seem to be not different significantly. Well, this is the analysis for ITT population. It showed that both group, lactulose group and PEG group, has induced improvement of spontaneous bowel movement during the first week. Again, in another analysis per protocol population, we found a similar result that the PEG group and lactulose group has induced the improvement of spontaneous bowel movement, and both group not significantly different. So I think non-inferiority has been proved in this study. What about the symptom scores? We can see from this slide that if we compare the symptoms between a PEG group and lactulose group, mostly not significant in terms of hard, firm, soft, loose, watery, strain easy, loss of control, non-mild, moderate, severe, and some other symptoms such as flutters, also not different between both groups. So all symptom score, including stool consistency, stool passage, cramping and rectal irritation, and flutters seems to be not different between both groups. Uh, well, again, the similar result also found from per protocol population. What about safety? If we look at some adverse event concern about nausea, bloating, epigastric pain, abdominal pain, diarrhea, cephalgia, and vomiting, we can see here clearly that abdominal pain again is much lower in PEG groups. Well, these are some adverse events according to ITT and per protocol population, mostly uh, uh, adverse event seem to be not different in both groups. Well, in conclusion, I think I can conclude that this study confirmed the efficacy of both PEG 3350 and lactulose for the relief of chronic constipation, and non-inferior was proved in this study. PEG 3350 was non-inferior to lactulose in these two cohorts with chronic constipation. And interestingly, flatulence was less reported in PEG 3350 group in this study. Well, thank you for your attention and good morning.
Thank you very much, Professor Modani, for the nice explanation, very concise and complete. And let us proceed to the next speaker. The last speaker is Dr. Ahmad Fauzi with the title, The Colonoscopy Preparation, the Role of PEG. Dr. Ahmad Fauzi is the Secretary General of the Indonesian Society of Gastroenterology. Please, Dr. Fauzi, the time is yours.
Thank you, Dr. Abinu, for this invitation and opportunity to speak here. And of course, thank you to Professor Ari, Professor Martin, and Dr. Kaka from Indonesian Society of Gastrointestinal Endoscopy that give me opportunity to speak here. And good morning to Professor Dadang and Professor Murdani. My assignment here is to speak about colonoscopy preparation, the rule of PEG. Is my voice here, Dr. Abinu? Can hear?
Yeah, I can see the slides clear and hear your voice, Dr. Fauzi. You can
Okay.
proceed.
Excuse me. Okay, I think this my slide about colonoscopy preparation, the rule of PEG, and we are all know that for doing colonoscopy, preparation is important because there is a risk of more mutilation and high cost if repeated, and adverse event, and of course not satisfied also to the doctor and the patient. Sorry. Here is the quotation from Abraham Lincoln. If I have 9 hours to chop down the tree, I'd spend the first 6 sharpening my eggs. So we have to prepare appropriately or very good before doing colonoscopy for bowel preparation. We know that colonoscopy now is the current standard method for imaging of the mucosa of the entire colon. But in large-scale review, incomplete colonoscopy, actually because of the inability to achieve cecal intubation and mucosal visualization effectively, is happening, occurring about 10 to 20%. And of course, it have impact to the diagnostic accuracy and therapeutic safety of the colonoscopy. and inadequate bowel preparation can result in failed detection of prevalent neoplastic lesion and also linked to an increase of risk of procedural adverse event. And this is a study from Shidu that from this study from 8,000 about 9,000 colonoscopy performed, around almost 700 was incomplete. And because of inadequate bowel preparation, the most common reason for incomplete colonoscopy. So accounting for about 25% of failed colonoscopy. Uh, so, uh, Sorry. Why is the quality of bowel preparation is important? Because there are some consequences. Like increased difficulty of colonoscopy, procedure time becoming prolonged, second intubation can be failed, and repeat procedure and shorter surveillance can happen. And the important is can reduce adenoma detection rate and exposure to higher malpractice risk. This is also additional risk is of course if repeated bowel preparation can have influence electrolyte imbalance, and repeated procedure uh, can give risk bowel preparation and complication from anesthesia. And this is some factors that associated with inadequate bowel preparation, like here is previous inadequate bowel preparation is a risk for not good bowel preparation. So we have to take history if the patient have inadequate bowel preparation before in the history of colonoscopy previously. And also older age, inpatient status, hospitalized patient also uh, bearing risk of inadequate bowel preparation, and of course some certain diseases like constipation, cirrhosis, diabetes, Parkinson's, stroke, and hypertension, and of history of colorectal surgery. Usually we evaluate the good bowel cleansing is by some bowel preparation scale, and usually the practical is Boston, and Boston bowel preparation scales is less invariable inter-observer comparing to other like Ottawa bowel preparation scale. And also we can take history about the bowel movement of the patient, because there is association between Bristol stool chart with inadequate preparation. Here the type 2, type 3, and type 4 is the higher risk of inadequate bowel preparation. And of course, the regimen preparation is can include considering the type. If we use osmotic or hyperosmotic, and also the volume, high volume 4 liter or low volume, and the timing, speed dose, how many hours to the colonoscopy, and also the preparation of low residue diet. Here some consensus. Our national consensus is 2016. I know 2020. I don't know if Professor Ari and or maybe Professor Dadang will revise this uh, in the coming years. And of course, the ASD also have a guideline about bowel preparation, and 2013, and then revised in 2015. And in ESGE also coming from the 2015 that updated to the 2019, and in the ESGE guideline is on 2015. Here is some some regimen of bowel preparation that usually use, including polyethylene glycol and some with sodium phosphate. I think in our country, or this is also some regimen usually used in US, and I think this is in European country with some dosing regimen and the type of hyper, hypo, or isoosmotic, and also the about the caution that state from their guidelines. And uh, usually in our country, what available is PEG electrolyte solution that can give in sorry, can give in a split dose or maybe in a single dose. Split dose with 2 or 3 liter before day before, and 1 or 2 liter in the day of procedure, or maybe a single dose 4 liter per day. And this is the PEG available here. Although in other countries there are some variation of polyethylene glycol. And here is there is a note that for sodium phosphate should be avoided with patient with renal insufficiency, and because acute phosphate nephropathy, and not recommended for routine use. This is some solution. Yes, the actually the polyethylene glycol electrolyte solution, what in our country we are know this as Niflake. Actually, this regimen is safe in renal failure, congestive heart failure, and even in liver disease. But the limitation is about the poor palatability and the need to ingest it more quickly. There are some other low volume of PEG, about 2 liter, but combined with other stimulant or osmotic active like ascorbat. But all other this preparation usually need to be careful in patient with renal insufficiency and some other condition like risk of ischemic colitis, and in a patient with, and sodium phosphate also not should not be used in patient with IBD and cirrhosis and congestive heart failure. And this is the safety from the European Society Guideline 2019. Actually, the high volume 4 liter of PEG is safe in many situations, except for congestive heart failure with NIHA class 3 or 4. So other condition is they said is safe. But the low volume is should be careful because the combination with ascorbic, citrate, and bisacodyl is should be careful in severe renal insufficiency. And bisacodyl can give in renal insufficiency, but also not recommend in patient with cardiac failure class 3 or 4. And if there is, and it's also with high dose of bisacodyl can there is a risk of ischemic colitis. So there in 2014 there are a guideline from ESGE. Actually, the split dose regimen of 4 liter is provide high quality bowel cleansing. So 4 liter single and split dose. The split dose regimen is better to provide high quality bowel cleansing. And of course, 4 liter PEG formulation is not superior also to low volume use 2 liter of the polyethylene glycol. And of course, PEG seems to be the most utilized when upon US population, especially restriction due to its because the PEG-ELS is isoosmotic. This is the recommendation from ESGE 2019. They review a meta-analysis and found that split dose regimens, regardless the type of dose and cleansing agent, actually provide excellent or good colon cleansing more frequently than day before bowel preparation. So split dose is recommended than single dose in the day before preparation. And this include all of the regimen, even PEG, sodium phosphate, or picosulfate. And split dose associated with a higher proportion of patient willing to repeat the preparation if needed. And this is some RCT that comparing identical cleansing agent about high volume and low volume and confirm that superiority of split dose than a day before regarding colon cleansing and patient tolerability. And about the adenoma detection rate is no difference about split dose and single dose. So split dose is now is a common usual regimen bowel preparation for colonoscopy. This study is compared split dose with the same day bowel preparation. Becoming evaluate is split dose comparing with same day bowel preparation. Actually, split dose and same day bowel preparation show similar result in the quality of bowel preparation, patient willingness to repeat, and of course, the also the overall tolerability. And patient with the same day regimen, but complain some also have less in bloating, and of course better sleep quality because not go to toilet in the night. And the ADR adenoma detection rate is similar in the split dose and same day. So most patients included in the study, but is scheduled in the afternoon colonoscopy. For the morning colonoscopy using polyethylene glycol preparation, the same day regimen significantly lower quality of bowel preparation in one study. But in two studies, they show similar efficacy of bowel cleansing, lower compliance, and but lower willingness to repeat the same preparation. Overall, this data favors split dose over same day in the ESG 2019. In some observational study also shown that there is an inverse correlation between the degree of mucosa cleanse and interval between last dose of bowel preparation and the start of colonoscopy. The best result if the interval is about 3 to 4 hours from the last dose. And this is some meta-regression analysis comparing split versus day before regimen, that the clinical gain from the split dose regimen was high within 3 hours from last dose intake, progressively decrease and will decrease after 5 hours. And what about the efficacy? Overall, some meta-analysis show that comparing sodium phosphate with PEG, and these two regimens demonstrated no difference in the rate of adequation preparation, but better score of sodium phosphate when only study using Ottawa bowel preparation. That we know Ottawa bowel preparation have variant inter-observer. With the OSP regimen, compliance was higher, but as well as acceptability, better taste, less nausea, vomiting, and no statistically significant difference in post-procedural electrolyte imbalance and creatinine level between the two regimen. Since the asymmetric analysis has been that OSP versus 4 liter PEG, both prescribed in split dose. The trial showed no difference in colon cleansing efficacy, in polyp detection rate, or in the rate of adverse event. Compliance to the regimen. This OSP is used 90 solution or tablet. But in 2008, there are some reports that sodium phosphate is uh, uh, in the patient with using sodium phosphate occur acute phosphate nephropathy. And comparing to polyethylene glycol, the occurring of sodium phosphate and acute phosphate nephropathy is very high comparing to polyethylene glycol. This is a study from 2001 to 2007 with a very high happening of acute phosphate nephropathy. And some cases is around 117 cases. This is 171 cases in sodium phosphate, and also there will be a nephrocalcinosis, but in PEG nephropathy is about 10 and no nephrocalcinosis. So after this report, the FDA alert that the use of oral sodium phosphate can use there is a risk of acute phosphate nephropathy. And in the so they changed the guideline in 2015 and said that sodium phosphate should be avoided in renal insufficiency and if there is acute phosphate nephropathy. And in the guideline, sodium phosphate should be avoided in patients with known or suspected also in inflammatory bowel disease. And sodium phosphate preparation should not be used in children younger age with those risk of complication and recommended for elderly patients. The ASG 2019 scrutinized about the safety of the sodium phosphate, and sodium phosphate, the most severe adverse event is kidney injury, and kidney injury can develop led to acute renal failure even in a few weeks after colonoscopy. And in a meta-analysis comparing effect of sodium phosphate with another preparation, in 7 control study, after that is showed that found no significantly association between sodium phosphate and kidney injury. But the committee said that this study is not powered to detect rare serious complication. But in what we see before that from until 2007, there were 171 cases of renal failure following USP, but related to PEG is just 10 cases. And there is estimated that acute kidney injury can happen approximately 1 per 1,000 sodium phosphate shown. Another severe complication is acute disruption of electrolyte hemostasis, including hyperphosphatemia, hypocalcemia, hyperkalemia, and hyper or hyponatremia. And the spectrum can be mild until to severe like death. Can cause death. And there is absolute contraindication of sodium phosphate, including pregnancy as less than 18 years, stage 3 to 4 chronic kidney disease, inability to maintain adequate fluid intake, if there is a pre-existing electrolyte imbalance, ascites, congestive high failure symptomatic, and recent symptomatic ischemic heart disease. Also, this is female 6. And There are some relative contraindication like active inflammatory bowel disease, parathyroidectomy, and delayed bowel transit. And we have to recognize this factor for acute prostate nephropathy also. It's including age more than 55 years, hypovolemia, baseline kidney disease, bowel obstruction, active colitis, and intake some drugs like diuretic, as inhibitor, S2 blocker, and NSAID. And renal function, some patients usually we even look like healthy. Sometimes we don't recognize if there is a chronic kidney disease. Actually, in older individual, elderly, because up to 23 to 36% people age 65 years older is have chronic kidney disease. Strategies to recommend to prevent acute nephropathy include, of course, avoidance of sodium phosphate in high-risk patients, screening chronic kidney disease, and avoiding dehydration, and maintaining a minimum of 12 hours between the administration of the sodium sulfate doses. There is ASGE actually released the guideline that sodium phosphate can bowel cleansing regimen and NSAID can be can cause mucosal change mimicking IBD, so it should be avoided in IBD patients. And there are some data also that PEG is more recommended for preparation of colonoscopy, and also, but we have to evaluate some social population like elderly, pregnancy, breastfeeding. In breastfeeding patient and stroke, dementia, about the use in IBD, sodium phosphate, picosulfate should be avoided because of mucosal damage and irritation. This is polyethylene glycol that we have in Indonesia that have isoosmotic and non-absorbed solution design. I think all the doctors know about this, and this is the composition with macro 4000, and used for colonoscopy, X-ray preparation, and colorectal surgery. And some side effect happening like vomiting, bloating, nausea. And this is our consensus of persiapan colonoscopy in 2016. They said that bowel preparation recommended is PEG, and in a special condition like children, elderly, patient with kidney disease, hypertension, consumption of inhibitor, recommended to use PEG. Actually, there are some study that compare split dose of 2 liter, split dose and low dose of polyethylene glycol, but it is combined with but in this study combined with ascorbic acid. And there are some non-split dose and split dose actually the split dose regimen is better. And what about there are some study also about split dose and same day for morning colonoscopy. The conclusion at the split dose reduced volume for morning colonoscopy is as effective as taking whole dose in the same morning, but is better tolerated and preferred by patient. There is the characteristic, and so the same day I'm sorry, the same day is I think also can consider. There is one study about polyethylene glycol bowel preparation before colonoscopy. Actually, in this study is the population of this study is special in patient with risk of inadequate bowel cleansing and use a low dose, just 1 liter of polyethylene glycol bowel preparation, and this is compared with 4 liter of split dose PEG. In this uh, this is a single center prospective study, but a pilot study, and the patient have poor bowel preparation, risk factor of poor bowel preparation such as stenosis or bleeding or inflammation. This is divided into two groups. 1 liter in the morning, and group B is 4 liter split dose. 2 liter day before, 3 liter day before, and 1 liter in the morning. And this is the characteristic. Actually, the from the study, including 44 patients, actually optimal bowel cleansing between the group between the two group A and group B, is actually similar, not significantly different, and also in adenoma detection rate. And all of bowel cleansing is reach 64%. And here also say that the Bristol stool appearance is actually correlated with the optimal bowel cleansing. And of course, the BSS 6 is correlated with 100 achievement of adequate bowel cleansing. So the group A and group B showed no significant in sacral intubation rate, exploration time, withdrawal time, even in adenoma detection rate, rate of adenocarcinoma, and in optimal bowel cleansing is similar, 1 liter and 4 liter split dose. This is the chart of this patient, and they conclude that no statistical difference were found between the two groups in terms of successful bowel cleansing. So low dose and 1 liter PEG bowel could be introduced in for selected inpatient. So same day low dose can be introduced, but maybe this protocol can be studied in another center. This is a difference between the group, and some adverse event also including nausea, vomiting. So as a summary, selection of bowel cleansing regimen should take into consideration in the patient medical history, medication, and when available, the adequacy of bowel preparation reported from prior colonoscopy. Ineffective bowel cleansing for colonoscopy result in missed precancer registration and increased costs related to early repeat procedure. The rate of adequate bowel cleansing should be at least 85% and higher whenever possible. Awareness of medical factors that increase the risk of inadequate preparation and non-medical factors that predict poor compliance and with instruction can direct physician to the use of more efficacious or aggressive preparation regimens or more extensive education. And here I show osmotic agent polyethylene glycol containing preparation that are osmotically balanced with non-fermentable electrolyte solution, thus theoretically minimizing significant fluid and electrolyte shift. This preparation cleans the intestinal lumen to the cathartic effect that results from large volume lavage. Thank you. This is my presentation.
Thank you, Dr. Fauzi, for the complete and clear explanation Now we will enter this discussion session. Actually, there are a lot of questions, but due to time constraints, I will limit maybe to 3 to 4 questions. The first questions to Prof. Dadang, Prof.
Yes, Dr. Abi.
Yeah, from Dr. Muhammad Ranushar from RSUD Baru, Sulawesi Selatan, Prof. Oh, it's far away. Thank you for participating, Dr. Ranushar. His question is, how is the role of probiotics or prebiotics such as yogurt or kimchi, Prof? Kimchi is a delicious food from Korea, Prof. Kimchi for patients with constipations. Any experience, Prof, or evidence? Thank you.
Yeah, thank you. Thank you, Dr. Abi. Thank you, Dr. Rio
Ranushar, Prof. Dr.
Ramsar, yeah. Okay, thank you. I think included in the global statement from WGO, World Gastroenterology Organization, that mentioned the beneficial effect of the use of probiotic in the management of chronic constipation. Some report with the specific strain of probiotic show the good effect to increase the number of spontaneous bowel movement among patients with chronic constipation. But I think I don't have any experience about the use of kimchi. What is kimchi? Is a food
Kimchi.
or?
Food, Prof, from Korea, Prof. Usually for appetizer.
Yeah.
Delicious.
Yeah. But however, if you look at the report, some report, and also I have mentioned before, probiotic is one of the treatment modalities, even not the main modality, yeah, in the management of chronic constipation. However, the management of chronic constipation should be initiated with lifestyle modification, then laxative. This is the two major main modalities in the management of chronic constipation. But additionally, we can use other modalities such as probiotic. Yeah. I have no information about kimchi, but maybe later we can make a study about this food. Is there any beneficial in the treatment of chronic constipation? So thank you.
Thank you, Bapak Dadang, for the answer. Next question is Prof. Mudani for you, Prof. Is there any possible long-term side effects of using PEG 3350, Prof? Or can prolonged use can cause dependence or tolerance, Prof? The prolonged use of PEG 3350. Please, Prof. Mudani, maybe.
Yes. Yeah. Thank you, Dr. Abi. So far, we don't have quite good data for long term. The longest study available is 6 months. 6 months is quite safe. But if you look at our data, we can use only 1 or 2 weeks is more than enough to treat the constipation. And if the constipation is a chronic one, and we can use such deluxe as necessary basis. So I don't recommend for long-term use, but we can use as a necessary on-demand basis.
Yeah, and
to
it's
treat
twice.
constipated patient.
Yeah. Okay. Thank you, Prof. Mudani. And next question is for Dr. Fauzi, Doc. How do you prepare colonoscopy with restricted fluid intake, such as chronic kidney disease, maybe, or chronic heart failure? Do you modify the preparations of the PEG or the NIPLEX, Dr. Fauzi?
Yeah, thank you, Dr. Abi. Actually, in chronic kidney disease or renal insufficiency, the choice of bowel preparation is the use of PG. And actually, even the 4-liter PEG said safe in patient with chronic kidney disease. Even in 4-liter with split dose, 2-liter and 2-liter. And also they said the safe also is low volume 2-liter with bisacodyl. It's also safe in severe kidney disease. But in reality, usually we coordination with the nephrologist. If we said to give a 4-liter, usually the DPGP or DPJP or nephrologist is afraid about the volume, even if it is said in kidney disease because of non-absorbable. So usually we compromise to give 2-liter. But what interesting is actually before as said by Prof. Dadang before in IDW, before PEG is used with 4-liter, and now coming some study that actually low dose, split dose, and then low dose 2-liter, and now coming some study with a small dose 1-liter, and even in the same day is actually better or similar with the 4-liter. So we do not need to give much amount of volume if we afraid about the chronic kidney disease. But the important is, I think, the time of colonoscopy. The time of colonoscopy is better to do in the interval 3 to 5 hours, and in some study use about 4 hours. So I think this what is the important. The timing of endoscopy. So now I think with the sub-study coming, we are more negotiable with the volume. If another doctor that coordinating with us is afraid about the volume 4-liter. But actually 4-liter is also safe in kidney disease for PEG.
Okay, Doc. So in the real situation, we can give 2 liters maybe, Dr. Fauzi, for CKD patients or
Yeah,
split those 2.
Evidence the 2-liter is same with a 4-liter. And even now it's very afraid. Some studies showed that 1-liter same day is also effective compared to 4-liter split dose. Yeah.
Okay, thank you, Dr. Fauzi, for the clear explanation. I think this one question.
Dr. Abi?
Yeah, Prof.
Dr. Abi, no?
Please, Prof.
Dr. Abi,
yep.
May I have a comment for the Dr. Fauzi's statement, because it is very important.
Yeah, of course, Prof. Please.
Very important to be understood by all doctors who are involved in the endoscopy procedure in our daily practice. The use of PEG is delivered with 4 liters. It's a huge of water, even for people in Caucasian ethnic, Caucasian race. Yeah, 4 liter is not. It's not convenient volume to be administered to all patients before colonoscopy. Then reduce to 2 liters. Then in our experience, 1.5 liters. And I think finally, and we are going to conduct a study about the use of small volume of PEG with 1 liter. Yeah, 1 liter of water. Yeah, maybe administered in the same day of colonoscopy procedure, or at least 12 hours before, and maybe with additional laxative, such as bisacodyl, or maybe with the use of prokinetic. So I think this is very important if we have to undergo colonoscopy among patients with restricted water intake.
Yeah.
So this is my comment.
Okay.
Thank you.
Yeah, thank you. Thank you, Prof. Dadang. This is, I think, the last question from Dr. Billy for Prof. Dadang, Prof. From Dr. Billy Pekanbaru, Prof.
Yes.
critical illness patients, usually in ICU, yeah, Prof. How do we approach and assess the constipation that seems to be overlapping with the critical condition, yeah, Prof? In ICU patients, the constipations, is it the same, Prof, the approach?
Yeah, yeah, I think it is a good question,
Yeah.
especially when we in our daily practice manage patient hospitalized in intensive care unit, that all patient with immobilized is prone to be to have constipation. So I think the management is not exactly different.
Yeah.
Maybe the use of laxative should be given promptly, yeah, to prevent the possibility of stool infection, because a patient with acute onset constipated condition during their hospitalization, sometimes we have to be aware about this possible complication. Maybe the use of lactulose is the first choice, man.
Yeah.
And then if there is no response, I think, as we have already known that nowadays in Indonesia already available, the small dose of PEG, yeah, and diluted in 1 glass of water, it means 250 milliliters. PEG 3350, as Professor Murdani mentioned before. I think the name is very good to be heard. Deluxe, yeah. Deluxe is convenient, I think, and then could be administered through nasogastric tube, especially in patients with restricted water intake.
Yeah.
I think that is my comment, Dr. Rabinu.
Okay, thank you, Prof. Dadang. Prof. Murdani, maybe you have additional comments regarding this issue, Prof. Murdani, in critical patient?
No, thank you.
Okay.
I think this is all. Okay, thank you, Dr. Rabinu.
Okay, thank you very much. I think we have reached the end of the session. Please give applause to all the speakers. Thank you very much, Professor Dadang, Professor Murdani, and Dr. Fauzi for the comprehensive explanation. Now I will get back to the MC, Dr. Saskia. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Warahmatullahi wabarakatuh.
Thank you very much to all speakers and moderators for a very insightful symposium. So we will have a photo shoot, Prof. and Doctor. So you may please look at the camera. I will count in 1, 2, 3. Okay, once more. 1, 2, 3. Okay, thank you very much to all professors and doctors. And also I would like to say thank you to Meiji as our sponsor. Okay, ladies and gentlemen, now we will go to the next symposium. The topic is about recent management of GI diseases, sponsored by Fresenius Servier Sanbe. For this symposium, it will be moderated by Dr. Bradley Jimmy Waleleng from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, University of Samratulangi, Professor Dr. Kando, General Hospital, Manado, Indonesia. So without further ado, I would like to invite Dr. Bradley Jimmy Waleleng to please lead this session. Thank you.
Thank you, Dr. Saskia. Thank you for organizing committee, especially Prof. Marcel, Prof. Dadang, and Prof. Ari, and others to give opportunity to me for this session as a chairman. Today, the last session, Symposium 7, we have 3 speakers. The first speaker, sponsored by Servier, with title Non-Surgical Management of Hemorrhoid. As a speaker, Dr. Indra Marki. And then second, role of omega-3 in pancreatitis and other diseases, sponsored by Fresenius. As a speaker, Prof. Ari Fahrial Syam. And the last session, and then last speaker, this topic, diagnosis and treatment of IBD. As a speaker, Dr. Wisnu Wardana. First, we invite to Dr. Indra Marki to present this topic about the non-surgical management of hemorrhoid. Dr. Indra, time is yours, please.
Thank you, Dr. Jimmy, for the moderator. And for my professor, my senior, and my colleagues, and for all, I want to share about the moment. Have you seen, Dr. Jimmy?
Yeah.
Clear?
Not clear. Okay.
Okay. Oh, loading moment. Okay. Yeah. I want to present about the non-surgical management of hemorrhoid. The first of all, the beginning with we see the outline, epidemiology, definition, risk factors, pathophysiology, diagnosis, and classification, management.
Indra, no good sound. Maybe you didn't have your sound, your voice.
Dokter Jimmy, mohon izin, Dokter Indra koneksinya mungkin buruk, jadi keluar dari Zoom, boleh dilanjut sesi pembicara kedua dulu aja kali, Dok.
Oh, ya. Okay, thank you, organizing committee. Because trouble in connection, we move to the second speaker, Prof. Ari Variceal will present the title, Role of Omega-3 in Pancreatitis and Other Disease. Please, Prof. Ari. Prof. Ari is Dean in Medical Faculty, University Indonesia. I think we already know who is Prof. Ari. Please, Prof. Ari, time is yours. Please, Prof. Ari.
Okay, yes, thank you, Dr. Jimmy. Okay. Okay, yes, first of all, I'd like to say thank you to the participant who still stay in the session. So, okay, I will share screen first. Okay, Dr. Jimmy, can you see my slide?
Yeah, it's clear.
Okay, good, thank you. Yes, today I will talk about the role of omega-3 in the pancreatitis and other disease. So I think this is the important topics for us, especially first, because you know that the pancreatitis patient is sometimes with high mortality and then many complications. So that's why we must give first we must know how to make diagnosis, and then what is the best treatment for our patients with acute pancreatitis. Okay, so the outline of my speech today is definitions, pathophysiology, diagnosis of acute pancreatitis, and then management of pancreatitis, and nutritional support for acute pancreatitis, and also the role of omega-3 fatty acid as a nutritional supplement in acute pancreatitis, and also some disease I will mention later. Okay, yes, were eliminations, acute pancreatitis and acute inflammatory process of the pancreas with variable involvement of other regional tissues or remote organs systems. So you know here this is our pancreas, the locations of pancreas, and this is common bile ducts. Yes, so one of the cause of pancreatitis because you know that the obstructs of the common bile ducts. Yeah, here I show the pictures, and if the patients with common bile stone in the common bile ducts, they will obstruct around here, and then they will be induced acute pancreatitis. Yeah, we must know about this pathophysiology because we will be correlated how to manage these patients. First, if something wrong with the pancreas, there will be produce thymogen activations and cellular injury. And then the other things, they will induce immune responses, and from immune responses, they will impact to what we call it the produce inflammatory mediators. So these conditions impacted oxidative stress and redox status. Okay, and from this, we know that there will be ischemia, reperfusion injury leads to gut barrier failure. And after that, they will go to bacterial translocations, and then they'll go to endotoxemia, sears and mold. So in these conditions, severely of acute pancreatitis, patients risk to mortality. So the next question is how to prevent systemic complications during severe acute pancreatitis. That will be mentioned that, later. Yeah, I just give you to show you about what is the conditions that predispose to acute pancreatitis. Obstructive, I mentioned, obstructive due to the gallstone, tumors, parasite. Sometimes we find the helminth inside in the common bile duct, duodenal diverticula, anal pancreas, colloidal cells, and others. And also from alcohol, metabolic, infectious, vascular, like patients with leptospirosis. Leptospirosis can, as one of the predisposing factor to acute pancreatitis. And then trauma, post-ERCP, yes, around almost 10%, post-operative, hereditary, controversial like pancreas divisum, and some idiopathic. And yes, we must know that how to, there is some differential diagnosis of acute pancreatitis, biliary colic, acute cholecystitis, perforated holoviscus, like perforated peptic ulcer, mesenteric ischemia, intestinal obstructions, inferior wall myocardial infarction. So sometimes patients come to us with the epigastric pain, and then with like coronary artery disease risk factors. So you must think about inferior wall myocardial infarction as a cause of acute pancreatitis. And yeah, sometimes we must think about the dissecting aortic aneurysms, especially for elderly patients, and also ectopic pregnancy for patients, female in the productive. Okay, so here I will show you about the conditions of acute pancreatitis, especially have two phases, early and late. Early means then the first week, late in after first week. And then we must assess the severity of acute pancreatitis, like mild, moderate, severe. And we must assess in the first time when patients come to ER. And then actually there's two types of acute pancreatitis, edematous and necrotizing. Okay, so I think, and why we need to make two different things of acute pancreatitis, because you know that this will be correlated
omega 3 itu
before 4 weeks
inflamasi.
Peripancreatic collections, and then 4 weeks cirrhosis. Okay. Yes, it's about this about the epidemiology. I think this is important things for us. Well, I mean the U.S. Because of alcohol abuse, so many patients the cause of acute pancreatitis because of chronic alcohol abuse. And gallstone, as I mentioned before, cause approximately 40% of cases acute pancreatitis. And we must know that the gallstone pancreatitis is more common in women than men, and annual incidence of acute pancreatitis range from 13 to 45 cases per 100,000, and globally it's around 33.74 cases per 100,000 populations. And the healthcare cost in US is reported to be 2.5 billion US dollar. Okay, now, yeah, just give you information that the one of problems patients, the severity of acute pancreatitis correlations with the hospital malnutrition as well. So we must know that in our area, Southeast Asia, we know that the hospital malnutrition is highly prevalent conditions among our hospitalized patients. Yeah, just give you about the sign of acute pancreatitis. You know that the main clinical manifestation of pain, nausea, vomiting, increase of amylase and lipase, and then from radiology, ultrasound, and also CT or MRI, we can see that uh, the edema of pancreas. Yes, this is one of how we assess about the staging, you know, the severity of acute pancreatitis. I mentioned that we must assess on admission and also at 48 hours after hospitalizations. Okay, these are the things that I will show you that the acute pancreatitis is usually caused by cholelithiasis, hyperlipidemia, and alcoholism that I mentioned before. So small stones are more likely than larger stone to pass through the kystic duct and cause ambulatory obstructions. So we must be careful with the small stone than large stones. I mentioned about the diagnosis before, about the CT is the first choice for diagnosis AP and is the local complications. We must know that how the conditions of pancreas in these patients, and then from this we can make assessment how that we can treat with just only pharmacotherapy or and parenteral nutrition, or we must send our patient to the surgeon. Yeah, this is a clinical approach to the patients with acute pancreatitis. Yes, first we must know that how about the condition of these patients. Severe patients require serial and regular measurements of respiratory rate and also arterial oxygen saturation. Now is one of equipment popular in pandemic era, because you know that the we know that the one of symptoms of patients with COVID-19 that we call that happy hypoxia, and sometimes patient not problems with their breath, but the problems with maybe the saturations, arterial oxygen saturation drop, and pulse rate, and then also blood pressure and urine output. This is the important things that we must measure in our acute pancreatitis. And administrations of high flow oxygens, and then the good intravenous access is essential. So you must care about this when the patients come to the ER. You know, critically severe patients require central venous access. And I mentioned that the patients who really pain, epigastric pain due to the conditions of pancreas. So early analgesia is safe and crucial in relieving patients' distress and allowing proper assessment and nursing. Because you know this is important things to reduce pain for our patients. And again, you know, because patients come, maybe the history of vomiting before, so aggressive fluid resuscitation is indicated. Acute pancreatitis patient actually get hypovolemic secondary to vomiting that I mentioned, and also poor oral intake. And you must know that maybe these patients, if they fluid sequestration in the subspace in our acute pancreatitis patients. Okay, yes. Before, I mean, the protocol before mentioned that we must give early nasoenteric tube. So paper from Baker, this is a multi-center study from Dutch pancreatitis study group. to know, to compare between the early versus on-demand nasoenteric tube feeding in acute pancreatitis. You can see here that the primary composite in points, infections, not difference, and also secondary endpoints is not different as well, and death not difference, necrotizing pancreatitis not difference, and then all mechanical ventilations not different as well, and new onset organ failure also not different. So yes, we don't need to early nasoenteric tube. So actually, it on-demand nasoenteric tubes. Yeah, this is published in New England Journal of Medicine, 2014. Okay, yes, I mentioned about the role of nutrition here. Why we must care about the nutrition intervention? I mentioned about that how yes, the important things for us to prevent complications. I mean, first we must know assess the what is the severity of the case, and then we must give the best treatment for our patients when patients come to the ER. So here I saw you the picture about what is nutritional, why we need to nutritional intervention for our pancreatitis patients. Okay, it says yeah, you can hear I mentioned that there are some etiology factors here: gallstone, alcohol consumption, drug, genetic predisposition. Okay, and then from this we know that the from acinar cells, there will be release of trypsin and other activated protease, and also release pro-inflammatory cytokine. So in these conditions, enteral nutrition or parenteral nutrition prevent pancreatic stimulation and other benefit. And when yes, I mean, after release of pro-inflammatory cytokines, there will be local inflammations. So in these conditions, we need to give anti-inflammatory immunonutrients like glutamine, omega-3, fatty acid, vitamin, and also antioxidants. And in the and to if the pancreas necrosis and then pancreas infections and also organ failure, septic shock, this is maybe we can give probiotics stabilize the disturbed intestinal barrier homeostasis. So the nutritional intervention is correlated with the pathophysiology of pancreatitis to organ failure damage. Okay, yes, why indication for parenteral nutrition, malnourished patients prior to the attack or when the therapeutic period of starvation is longer than 5 or 7 days, and patients who are unable to reach complete nutrient goals, and gut failure. Sometimes patients with problems with the maybe ileus, and enteral nutrition is impossible. Patients with the ileus, sometimes patients with the paralytic ileus. So this is the indications that we give a parenteral nutrition for our patient. Okay, and then parenteral nutrition doesn't significantly stimulate pancreatic secretions in human, and and also there is no adverse effect of parenteral nutrition on pancreatic function and macronutrients, and also we give the parenteral glutamate supplementation, and the glucose will be preserved energy source, and it does not affect pancreatic secretion and functions. This is the directions how we give parenteral nutrition for our patients with acute pancreatitis. And now, how about the role of omega-3 fatty acid? So this is some clinical trials mentioned to compare, to see about the compare between the infectious complications, mortality. So from this is a method of assessment, Apache or CT severity index, Apache, and also in this study using Apache and CT severity index. And we can see that from the study, so compare between control and intervention, that the patients durations of hospital days is shorter in the intervention case compared with the control without intervention. And this is another study to what we call it to see about the fish consumptions as a hazard ratio in non-gallstone related acute pancreatitis. You can see here that the total fish consumptions is something like this: is 4 servings per week to reduce what we call that hazard ratio of non-gallstone related acute pancreatitis. So this is the importance of using fish, fatty fish and lean fish oil. Okay, this is another study. You can see here that the changes of immunological important PUFA, EFA, DHA, and DSAGLA, and arokinetonic acid in serum phospholipid. So you can see here the difference between patients with omega-3 polyunsaturated fatty acid in acute pancreatitis compared with the control. Okay, you can see here, and this in some important immunological important things. Okay, and what about the major clinical outcome variable and occurrence rates of complications between these two groups of PUFA and control? You can see here that that less of no multi-organ failure, and then less sepsis here, and then also mortality. And all patients, I mean, complications is less than control. Okay, this is one position paper from ASPEN about the clinical role for alternative intravenous of fat emulsions, so that fish oil less pro-inflammatory than other oil. Okay, this is another things about the immunoinflammatory modulations by omega-3 fatty acid. So you can see here that the hyperinflammatory excess inflammatory and immunosuppressions in the role of omega-3 fatty acid. Yeah, you can see here that there will be increase, there will be suppressed immunosuppression. Okay, so it will be improved outcome, and then resolving, protecting. Okay, and then this is another things, that the value of omega-3 fatty acid in preserving muscle. You can see here that there will be increased muscle protein synthesis in the cancer, cachexia, and also muscle disuse, aging, and pre and post surgery. Another role of omega-3 fatty acid. Okay. Yes, this is one mention about the consensus statement 2020 from Mayers about the lipid use in hospitalized adult recurring parenteral nutrition. Actually, there is sufficient scientific evidence for clinical trials, systemic reviews, and meta-analysis to demonstrate that fish oil containing intravenous lipid have advantage over standard intravenous lipid without fish oil, and when used in adult surgical patients requiring parenteral nutrition. And then this consensus 100% agreement. And when parenteral nutrition in adult surgical patient is required, consider including fish oil containing intravenous lipid where possible. So around 94% agree of this consensus. So this is a good consensus. This is good information from the consensus about the role of fish oil containing intravenous lipid emulsions. Okay, this is another. I mean, the new of prominent role of IV fish oil in therapy for COVID-19. This is the important things for us. Actually, it is published 2020 in January, a couple days ago, about the parenteral fish oil and adjuvant pharmacotherapy for coronavirus disease 2019. So omega-3 fatty acid from fish oil have several anti-inflammatory and pro-resolving properties, and sole parenteral infusions of pure fish oil emulsion has been proposed as a pharmacotherapy. And from this, mention about that harnessing inflammation resolving based therapy agents to treat pulmonary viral infections. So the possibility of the role of this IV fish oil, intravenous lipid emulsions for treatment or supporting treatment for our COVID-19 patient. This is one of the examples, the products in our market using this fish oil. You know that the lipid in this for 28 actually for 28 for 1 liter. So the lipid from soybean, and then it's important here have fish oil enriched in omega-3 acid. And also, I think because you know that the osmolarity below 900, we can use as a peripheral. This is one of the examples of products that in our market here in Indonesia. Okay, Dr. Jimmy, as a chairman of this session, and also ladies and gentlemen, so the conclusions of this my talk is again I mentioned that acute pancreatitis is a common acute inflammatory disorder and leading cause of hospital admission, and clinical manifestation of acute pancreatitis vary from mild edematous form to severe fulminant pancreatitis with potential devastating complications. Emerging evidence, I mentioned that before, in light of the current state of pathophysiology of acute pancreatitis, has highlighted that strategic initiations on nutrition with appropriate nutrient supplementation, for example, using the lipid emulsions, are key to limit local inflammation and to prevent or manage acute pancreatitis associated complications. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ari, with your explanation about your topic. I think it's clear. Next, we back again to first speaker, Dr. Indra Marki.
Yes, I'm sorry, Dr.
Surgical management of hemorrhoid. Please, Doctor.
I'm sorry for you because the connection. Moment. This. Can see clearly, Dr. Jimmy?
No. Okay.
Okay. Yeah, thank you. Sorry for the connection. Okay, I continue the non-surgical hemorrhoid management. For the first we can see the outline, epidemiology, definition, risk factors, pathophysiology. Clear ya, Dr. Jimmy ya? Diagnosis and classification, management, and take home message. Yeah. We know that. Oh, what's this? I can see this. We know the new published about the hemorrhoid this October 2020. Is the prevalence, characteristic, and treatment. We know this the 6% in Brazil, 7% in France, 16% in Italy and Russian, 9% respondent in Czech and Republic, 10% Romania, 11% in Spain. We can see this the epidemiologic. This male is 44%, females is 66%. Age is the 18 until 40 is 35%, 41 until 60, 51%, more than 60 is the 14%. And we know the definition is we know that the hemorrhoid is developed when the supporting tissue of the anal canal disintegrate and deteriorate. The abnormal downward displacement of the anal canal causing venous dilatation. You can see this, the hemorrhoid. This hemorrhoid interna is above the linea dentata and externa is below the linea dentata. This the risk factors: aging, obesity, pregnancy, condition related to increased intra-abdominal pressure and constipation, prolonged straining, and low fiber and alcohol. You can see this pathophysiology. This is the mechanical theory and hemodynamical theory. We know the mechanical theory that's the hemorrhoids are associated with the condition that increased pressure. Hemorrhoid venous plexus that supporting tissue the anal canal disintegrate. We can see this, the mobilization of the plexus, stretching of the support system, hemorrhoidal tissue in the left picture, prolapsing and straining, then finally rupture of anchoring tissue permanently after that stretching and rupture the park ligament. And the hemodynamic theory is the AV dysfunction. When the superior hemorrhoidal artery blood flow increase, can make the opening of the EV shunt. So after that, the tissue less the nutrition and can make the precapillary sphincter spasm. And after that, hyperpressure and dilatation of the hemorrhoidal venous plexus. We can see this clinical manifestation is the pain, 60%, anal bleeding, discomfort is 43%, itching, 35%, swelling 33%, rectal prolapse 15%, using is 9%, and discharge is 6%. And we can see this the diagnose, this patient taking the history and symptom, and I saw the slide before, and digital rectal examination, and patient in the left lateral position. You can see the external hemorrhoid, perianal, dermatitis from the anal discharge for fecal swelling, and abnormal anorectal mass, anal stenosis. In anoscopy, we can see the hemorrhoidal size, location, severity, and inflammation and bleeding. And colonoscopy, we can see allow excellent visualization. This the classification of the hemorrhoid. We can see this the classification Groliger. Can the internal hemorrhoid is the above linea dentata, and externus is below the linea dentata. It makes the both external dan internal hemorrhoid. Grade 1 is anal cushion is bleed but do not prolapse. Grade 2, anal cushion is prolapse through the anus and straining but they reduce spontaneously. And grade 3, anal cushion is the prolapse through the anus and straining and is a certain and required manual to the anal canal. And the grade 4, prolapse stay out all the time and irreducible. This we can see the picture, grade 1, grade 2, grade 3, and grade